Trauma is the leading cause of global mortality. Accidental trauma leaves 45 million people worldwide with moderate to severe disability. Remember, all parts of our bodies are vulnerable. Trauma is a physical injury or wound produced by an external force. It may result in mild or severe damage. This can include soft tissue injuries, fractures, bleeding and tearing of blood vessels and vital organs, amputations, and complex regional pain syndrome. This type of injuries can account for 1 in 6 hospitalizations and up to 30% of ICU admissions. There's 2 major types of trauma: penetrating, such as gunfire wounds and stabbings, and blunt, caused by a blunt object, such as a collision with a blunt surface, a motor vehicle accident, falls, or assaults with blunt objects. The most common cause of trauma-related death and disability can be deceptive. The true nature of the injury is often hidden, and evidence of serious injury may be subtle or absent. Multiple trauma is the leading cause of death in people under 35 years of age in the U.S. Injuries commonly include pelvic fractures, which occur up to 30% of the time, and crash injuries. What is the most common cause of injury in people over 65? Falls, resulting in often fracturing of the hip and proximal humerus or vertebras. And what can mask the effects of pain and immobility? Are you thinking alcohol? Alcohol is usually an implicator cofactor when associated with trauma. It also has a direct cardiosuppressant effect. Low blood pressure, low heart rate can be profound in musculoskeletal injuries in patients who have heavily drunk. Keep in mind that approximately 40% of motor vehicle accident mortality has been associated with driving while intoxicated. Unintentional injury is the leading cause of death in the United States for people between the ages of 1 and 34. Be aware that less than 10% of patients with traumatic injury have life-threatening condition, but life-threatening problems may occur with only subtle signs and symptoms, such as internal bleeding and shock. Mechanism of injury is the process and force that causes the trauma. This is important as different mechanisms of trauma have predictable patterns of injuries that may result. For example, in a vertical fall, knowing the distance of the fall, the body parts that impact first, and type of landing surface will help anticipate the extent of the injury. Falling from greater heights increases the incidence of trauma because velocity increases as they fall. Falling on an outstretched hand can lead to a distal radius fracture. Hitting with a closed fist usually causes a boxer's fracture at the 4th and 5th metacarpals. You see, we need to have an index of suspicion, meaning that we need to anticipate the injury to a body region, organ, or structure based on the mechanism of injury. We'll cover trauma nursing assessments more in depth in your last quarter of your nursing program, but briefly we'll discuss that priorities are based on life-threatening potentials. So, triage. We need to first manage the sickest viable patients. In an immediate trauma resuscitation, assessment and interventions are merged. Obvious injuries may not be the most serious. With any trauma, there is a systematic process of assessment. So an initial evaluation includes a focused primary survey and an in-depth secondary survey. When we talk about the primary survey in trauma, we always start with ABCs. Now keep in mind that recent American Heart Association changes to CPR. Now we remember CAB in arrest, meaning circulation, airway, and breathing. Let's talk about ABCs during the primary survey. A. Airway. Secure the airway with simultaneous cervical spine protection, immobilization. Always assume cervical spinal injury. It means the patient has to use a collar or a backboard. Pay attention to a patent airway. Suction. What's a good indication of a good airway patency? Voice quality. B. Breathing. Assure adequate oxygenation and ventilation by the use of a bag mask valve. Inspect, auscultate, and palpate. Check an O2 saturation, fix tension pneumothorax and hemothorax at this point. Check for breath sounds. Does the patient need to be intubated? Circulation. Check perfusion, pulses, blood pressure, capillary refill, pallor, cyanosis, level of consciousness. By the time hypotension develops, all compensatory mechanisms used during the state of shock are exhausted. This is a big deal. Identify and control hemorrhage of open bleeding wounds. Direct pressure is going to be important in this case. Internal bleeding leads to more hidden complications. If the patient is in shock, suspect this. And immobilize long bone or pelvic fractures. Do you know how you can quickly and easily estimate a blood pressure without a cuff? By palpating the presence or absence of a peripheral or central pulse. If you feel a radial pulse, blood pressure is an estimated 80. Femoral palpation, the blood pressure is at least 70, and if it's a carotid only, at least 60. D is for disability. When you think disability, think about neurostatus. Check level of consciousness, assess response, obtain a Glasgow scale, remember that's pupil, gross motor, and sensation, or an APU scale, alert, voice, pain, and unresponsive. E is for exposure and environmental control. Expose the patient or we will miss injuries. We may need to cut clothing. Also consider the importance of preventing hypothermia, depending the situation. Now, there are important considerations in a multiple trauma patient as we move from the primary to the secondary assessment. Is there a potential or an actual fracture? Remember, we have 206 bones. Protect them. Handle with care. What can manipulation cause? A more serious damage. If there's movement with a cervical fracture, that can lead to lifelong disability. Broken ribs may not only initially pose a serious problem, but with rough handling, it could also lead to a pleura or lung injury. This is going to lead to increased pain and increased blood loss. We need to splint above and below the joints. Cover open wounds with sterile dressings and direct pressure if there's bleeding. Well, what are the key points of the exam? Inspect for fractures, angulations, shortening of the limbs, open wounds, changes in color, swelling, muscle spasm may indicate a hidden injury. Check range of motion. Is there any crepitus? What about neurovascular checks? CMS. Please remember, do not move an obvious injured extremity to check for range of motion. After the provider reduces a fracture, nursing care of the patient with fracture must be observed. Consideration with fixation devices, fracture sites, mobilization, psychosocial needs, and rehabilitation are all important. A trauma secondary survey or assessment includes vital signs. After the primary survey, now we go through a more thorough history and physical exam. We review the entire body to discern and manage any injuries we may have missed during the primary survey. This is going to include a thorough physical examination. Common pitfalls are not thoroughly inspecting the back, axilla, gluteal, and pannicular folds. Particularly important if we suspect a penetrating trauma. Is there pelvic instability? If this is the case, we need to provide stability and control any retroperitoneal hemorrhage by applying a pelvic binder. If the patient is needing to be intubated, we need to check for placement of the ET tube. Also during this time, further assessing, monitor, inserting Foleys and IVs. Diagnostic studies. This is going to include blood tests, radiology, and etc. Do you know what the big three means? The big three is used in ER often, implying the need for a cervical spine, chest x-ray, and pelvis. The big five is the three we just discussed, plus a thoracic and lumbar x-ray. What about a FAST, F-A-S-T? That is a focused assessment by sonography for trauma. It assesses for free fluid and blood. Do you think a negative FAST rules out injury? Definitely not. Well, what if there's any changes? We need to go back to ABCs, and if arrest, CAB. Is there an overt need for surgery? The patient will need to go to the OR without further studies. Remember that the patient must be stable in order to go to the scanner. That's the last place you want to be to resuscitate a patient. There's different phases in trauma care. The resuscitation or emergency phase. That's where triage decisions need to determine the best level of care required. Stabilizing the patient, rapid transport, stopping blood loss, and starting IV fluids, typically 2 to 3 liters or 20 cc's per kilogram in kids. Decisions for blood transfusions are made here. The operative phase is the damage control surgery decision-making, or definite surgery after correction of acidosis, hypothermia, or coagulopathy. Critical care phase is where the patient remains critical and is transferred to intensive care. During this phase, breath sounds, ET tube placements are checked, patency of IVs, neurological status, history of any underlying chronic conditions, such as renal disease, malignancy, or cardiac disease, as all those increase the mortality and morbidity of patients that are hospitalized longer. Also, patients with drug and alcohol dependency are more likely to have complications and ICU hospitalizations. Intermediate phase in rehabilitation is where the patient is moved to the floor or to the rehab center, if not discharged home.